Good afternoon. It's my pleasure to welcome you to the 2013 ASCO Annual Meeting Educational Session, Prostate Cancer Screening, Past, Present, and Future. Before we begin, I would like to acknowledge the ASCO Education Committee and particularly thank Dr. Tony Choueiri of the Dana-Farber Harvard Cancer Center and the ASCO Educational Committee who oversaw the session's development. There are 5 educational objectives for today's session. First, to understand current scientific evidence related to screening for prostate cancer with the prostate-specific antigen, or PSA test. The second is to understand recommendations from major current clinical practice guidelines in this area. Third is to appreciate different perspectives in the ongoing debate about who should or should not be screened. The fourth is to understand emerging screening strategies. And finally, the fifth is to appreciate how screening tests are regulated, particularly in the United States. We have a group of superb panelists today who I will introduce in the order of their presentations. In the second seat, we have Dr. Peter Scardino, who is a urologic surgeon and chair of the Department of Surgery at Memorial Sloan Kettering Cancer Center in New York. He is a pioneer in techniques to improve the effects of surgery on men's urinary and sexual symptoms and to maximize long-term control of disease. He has also been a leader developing prediction models and databases for understanding surgical outcomes, as well as tissue and genetic markers in prostate cancer. He will be speaking on how to optimally screen men for prostate cancer. The second speaker today, who's in the first seat to my left, is Dr. Timothy Wilt, who is a general internist and a health services researcher, as well as professor of medicine at the Minneapolis VA Medical Center and the University of Minnesota School of Medicine. His research policy and clinical work aim to identify and implement high-value healthcare in the areas of health promotion as well as disease detection and prevention. Dr. Wilt is a member of the U.S. Preventive Services Task Force, the American College of Physicians Clinical Practice Guidelines Committee, and the Department of Veterans Affairs Preventive Medicine Advisory Committee. He led the important clinical trial, the Prostate Cancer Intervention versus Observation, or PIVOT trial, which was published last year in the New England Journal of Medicine. He will be providing a counter-argument against PSA screening today. Dr. Harry de Koning, in the last seat to my left, is a professor of public health at Erasmus University in Rotterdam and is a member of the Medical Advisory Board of the Royal Netherlands Academy of Arts and Sciences. He has done substantial work throughout his career running large screening trials and guiding policy decisions related to cancer screening. He is the senior author of an important study on the quality of life effects of prostate cancer screening published recently in the New England Journal of Medicine that he will describe in his talk today. Dr. Philip Febbo, in the third seat to my left, is a medical oncologist and translational scientist at the University of California in San Francisco, where he is a professor of medicine and urology and leads the prostate cancer program. He is also principal investigator for the translational research program of the Alliance for Clinical Trials in Oncology, which is the largest of the National Cancer Institute cooperative groups in the United States. He was the first to publish a multi-gene expression-based predictor of prostate cancer recurrence after surgery and has identified mechanisms of resistance associated with androgen ablation and with a number of therapeutics. He has consistently focused on the incorporation of expression analyses into clinical trials. Today, he will be discussing emerging approaches for prostate cancer screening. And finally, I will serve as today's session moderator and as the final speaker on the panel. My name is Ethan Bash. I'm a medical oncologist and a health services researcher at the University of North Carolina in Chapel Hill. I chaired ASCO's recent guideline panel on PSA screening and serve on the board of scientific advisors of the National Cancer Institute and on a methodology committee of the Patient-Centered Outcomes Research Institute, or PCORI. In my talk, I will focus briefly on regulatory issues related to screening tests like PSA. Each of the speakers will speak for approximately 15 to 20 minutes, and we will hold questions until all the speakers are done. Our session goes until 3:15 p.m., so we should have ample time for questions and answers. I will ask audience members to keep the duration of questions to under 30 seconds if possible, and to keep these restricted to questions to the panel rather than policy or opinion statements. As brief background, PSA screening came into widespread use in the 1980s in the United States after which time the incidence of prostate cancer diagnosis sharply rose and mortality attributed to prostate cancer slowly progressively declined over subsequent years. The extent of PSA screening's impact on this mortality decline, as well as the balance between harms and potential benefits related to PSA screening, have remained highly debated to this day. Multiple observational studies, 2 large randomized controlled trials, and additional related studies that will be discussed today by the panel have aimed to enlighten this debate. Although major clinical practice guidelines have recently come into greater alignment with each other, differences do remain. Last year, the U.S. Preventive Services Task Force recommended against PSA screening in all men. ASCO followed shortly thereafter, agreeing with this approach only for older men, but advising informed decision-making in younger men. Last month, the American Urological Association substantially revised its prior recommendations by advising against screening in men 70 or older, as well as in those below 55, unless at high risk of disease, with informed decision-making suggested for those between the ages of 55 and 69. These recommendations are similar to those recently issued by the American College of Physicians. So what should clinicians advise? What should men do? Where is this field going? With this introduction in mind, it is my pleasure to introduce our first panelist, Dr. Peter Scardino.